Can you hear me?
Yes.
We're good.
All right, my apologies for the delay, but I got the timelines mixed up. I thought you were on Eastern time, not Central time, so I had my clinic schedule sort of all screwed up after having changed it several times. So now we should be on. We should be okay for the next 30 minutes, hopefully. So without further ado, I was asked to, first of all, I'm Dr. Steve Falchuk, and I was asked to speak to you today about the what we've been doing with electroencephalograms and sort of the general topic of maybe epilepsy, or at least epilepsy management in RCDP. To begin with, I'm going to advance it this way because this way I have a little bit better control over it. Is this big enough for everyone to see?
Yes. Yes. Yes.
Yeah. So the only declaration I have regarding this is that, I am a participant in the study of the natural history of Rcdp switching from Tata with funding by Midlife. So let's start with what is an EEG and why does it happen? Okay, so basically, hopefully this is big enough for you to see, but these three cartoons demonstrate what goes on in every single neuron, every single brain cell or spinal cord cell for that matter, or peripheral nerve cell. So, and in the resting state, there is an imbalance in sodium and potassium ion concentrations. And this results in a negative membrane potential of about minus 70 millielectron volts. What happens when a nerve is required to conduct an impulse to send a signal is that there's an opening of sodium channels that allow sodium ions to flood into the inside of the cell, which results in what we call a depolarization. So not only does it depolarize to zero, but it actually goes a little bit positive, so that the membrane potential, called the action potential, is about 20 millielectron volts positive to the inside of the cell. And then there's a recovery phase where there's an energy-dependent pumping of sodium ions out and potassium ions back in that results in this slight hyperpolarization of minus 100 millielectron volts that then sets this cell up to be able to fire the next volley of electrical signal. And these are basically just like signals traveling along the wire in your telephone cables. Old telephone cables, now everything's fiber optics, so they don't work that way, but basically any sort of conductor that conducts electrical signals, this is conducted along the surface of the cell membranes, and that's more or less the basic physiology of it. So what is an EEG? An EEG is an array of what we call differential amplifiers. What it does is it detects the summation of electrical potentials, hopefully to provide some insight into what is going on within the brain. Any single brain cell, a neuron, is not able to generate activity that is high enough in amplitude or long enough in duration to be able to be detected by electrodes on the scalp, because your scalp is really pretty far from your brain surface, and the power of the brain as far as electrical power is really quite low. So if you see those cartoons where somebody gets an idea and this light bulb goes off above their head and it's an old 60-watt light bulb, it really should be like one of those little Christmas lights, because your brain only produces a couple watts of power. It's an incredibly efficient machine, so it doesn't require vast amounts of energy to function. The EEG is a summation of the EEG tracing that you see, that we're going to show you in a minute, is the summation of the activity of many, many, many neurons, millions of them. And what you're seeing is sort of these, what are called postsynaptic potentials. So this part here, where you get this sort of like hyperpolarization and you get this buildup of ions on on the outside of the cells, and you see it'll cause changes in the waveform that you see. And, it's just been estimated, this is a very crude estimate that I'm not sure I believe, but that you need approximately 6 square centimeters of brain tissue functioning simultaneously in order to detect any deflections on the scalp surface EEG whatsoever. And so what we have is a differential amplifier is always schematically represented by a triangle with 2 inputs and 1 output. So you have input 1, which we call grid 1, input 2, which we call grid 2. And the output is this channel, which is simply subtracting 1 from 2 and then amplifying the difference. We're talking about these tiny, tiny potentials. So by the time these summated potentials get to the scalp surface, they're from these many millions of neurons. We're talking about potentials in the order of magnitude of like 10 to 20 millivolts. A millivolt is 1/1000 of a volt. Millivolts is 1,000. They're microvolts, 10 to 20 microvolts, which is a microvolt is 1/1,000,000th of a volt. So we're talking about 10 to 20 millionths of a volt of electrical power. So that needs to be amplified because there's no way that otherwise that would ever be detectable by any other means. So the amplifiers do that job for us. And basically there's rules of polarity that I'm not going to bore you with too much. But when the input to grid 1 is relatively negative compared to grid 2, for reasons that are very strange and dated in history, the deflection of the pen or of the line of the tracing is upward, and when grid 1 is relatively positive compared to grid 2, the line goes down. All of these are applied in an international schematic, so the odd numbers are on the left side of the head, the even numbers are on the right side of the head, and there are internationally agreed naming. So the T is usually stands for temporal, F is frontal, C is central, P is parietal, O is occipital. And then these inputs from each of these electrodes is compared to another electrode. And this array of processing of how the amplifiers are arranged is called a montage. And there's many different types of montages. The one that we use most commonly is called the longitudinal, or it's sometimes called the double banana montage, because if you sort of draw this out on the surface of the scalp, it almost looks like you drew 2 bananas on the surface of the scalp. But there's also referential montages where you pick one electrode or even an average of all the other electrodes and reference to it. And there's reasons why you would do that to try to get clarity on what it is you're seeing. The end result is you get this over here on the right, which is a nice normal EEG, and it has a very characteristic, very tiny appearance to it that is age dependent. It looks different as you go through life. A neonatal EEG looks a lot less organized, but it still, in fact, has an organization to it. The EEG is sort of like an older child or young adult, looks exactly like this when they're in the waking state. And we have different bandwidths for the different frequencies. These were named in the 1930s, and they were using Greek letters to name them. So the alpha frequency range was the first one that was detected. And so, so they went alpha, beta, gamma, delta, et cetera, et cetera. So some of the names have dropped out because they were decided that they really weren't very useful. So we're left with mainly alpha, beta, delta. There are gamma frequencies that we talk about as well, but we usually don't see those in routine scalp EEGs, but they're used sometimes if we do intracranial EEG monitoring for epilepsy surgery purposes. So the intent of the electroencephalogram is to provide a quantifiable and hopefully reproducible assessment of brain electrical activity. And this is exactly why we're doing this in children with Rcdps, because we are trying to follow them longitudinally and trying to have some sort of an objective measure as to what their brain is doing over periods of time. The EEG in broader, more common applications also can provide some risk assessment of the risk of seizure recurrence, the risk of abnormalities in global brain functioning, whether that's the whole brain or whether it's just one particular anatomic area of the brain. And it may also, in the right circumstances, give you some sense of either progression or improvement of a particular clinical scenario. It's important to understand, though, that an EEG is a time-dependent snapshot, and that no one particular moment in time tells the whole story. No particular 20 moments or 30 moments in time tells the whole story. In fact, you can record an EEG for many days in some people and still not maybe get a full sense of everything that's going on with them. However, you do have to draw the line someplace, and so we usually agree upon a standard monitoring period of time that seems to be sensible and that hopefully will give us enough of the snapshot so that we can sort of judge the details that we're trying to get a better handle on. EEG varies in a number of different ways, so it varies with age. As I told you, the EEG of younger children generally has a slower predominant frequency distribution. As you get older, it speeds up to a certain point, and then once you're about 20 to 25, that's about how it looks forever, unless, God forbid, you have problems later in life, and then you may get slowing or other changes. It also varies depending upon your state of wakefulness and sleep. The waking EEG looks very different from the sleep EEG. Medications greatly affect the EEG and can introduce either slowing or excess fast activity and a number of other phenomena. Sometimes some medications can even produce what we call epileptiform potentials, which we'll talk about in a moment, that you sometimes will see in people who are prone to or at risk of having a seizure. So sometimes medications in the wrong or right circumstance can actually produce those. Body temperature also affects the EEG. So one great way to make an EEG look like it's gone away completely, to the point where it may be hard to tell whether someone has met the criteria for brain death, is if they're too cold. If they're too cold, the EEG amplitude drops down so low that you often can't really see it very reliably. So somebody who's severely hypothermic may look like they have a flatline EEG, but they don't. When you warm them up, it's bad. Cerebral perfusion, the blood flow to the brain, will also affect the EEG. If blood flow is compromised to a particular area of the brain or to the whole brain, it will introduce lower frequencies, and initially they're high amplitude, and then if that continues, the amplitude will drop down, so you'll get a change in the EEG with that. EEG interpretation is scientifically grounded, but it is in fact subject to reviewer bias. So there is no algorithm or machine at this point in history that reliably produces an EEG, that reliably produces a reproducible EEG interpretation. This is still very much an eye of the beholder phenomenon. The reason for this is complex, but it has to do with there are so many variables, and in particular there's so many what we call artifacts. Much of what we see on an EEG is act from movement, eye blink, a number of different things that has to be weeded out, and the human eye and human brain is still the best machine to determine what's an artifact versus what is real. And machine learning doesn't seem to be able to quite keep up with that so far. It's also important to know that the correlation of EEG with clinical states is not exactly one-to-one, that you can see someone whose EEG looks particularly disturbed and they're fine, and you see other people whose EEG looks normal and they're definitely not fine in their function. Anyway, I'm trying to speed up a little bit, but basically this just demonstrates what we have when it comes to EEG. So the brain down here, greatly magnified, and this is not to scale, in the surfaces of the cortex is where the electrical signals are occurring and the shifts in ion concentrations are occurring that generate these electrical fields that are then detected by this electrode. But honestly, if this were to scale, this area would be here, and this EEG electrode would be way, way, way up on the ceiling. So, you know, this is a very, very long distance on the scale of brain cells from where the generator is to where the detector is. So sometimes you get erroneous results on an EEG if you have just too much problem. And some things will actually make the EEG amplitude low, such as if somebody just has a very thick skull, or if somebody has what's called a subdural or subarachnoid hemorrhage. It can interfere with EEG transmission, or if somebody just has swelling of the scalp, it will actually reduce the amplitudes to the point where it may be very hard to detect a reliable EEG. We have some general categories of abnormalities, basically epileptiform, which are the ones that are statistically associated with increased risk of seizures. Seizures themselves, which are generally a series of rhythmic sustained discharges that are believed to represent a clinical event with or without an observable change in the individual, and we sometimes call them electrographic if there's no observed change. Background slowing, which usually is an indication of some degree of dysfunction if the frequency distribution looks slower than it should. Lack of normal organizational features, excessive discontinuity, leading all the way up to what we call burst suppression, which is where more of the EEG is almost flatline looking compared to showing bursts of activity. That's always very abnormal. And then also excess fast frequency activity, which can usually be associated with medication effects. But you also see that sometimes in people who have ADHD or just deficits of alertness. So this is actually the EEG of a child who has RCDP. And this is one of the more abnormal EEGs. Some of these children have normal EEGs, but some of them will be abnormal. And this EEG I'm showing you because it shows both generalized, over here if you can see my cursor, this is going on both the left, the odd number, and the even right, the even numbered side of the brain, simultaneously and pretty much to the same extent. And then all over the place there are these other phenomena which only show up on either the right or the left side, and those are focal abnormalities, where you have a focal area of electrical discharge. And when you have this spike or sharp wave, that usually means that there's been a very, very brusque and generally abnormal set of depolarization events that are usually more associated with a seizure, as opposed to these more rounded waveforms, which have a little bit more rhythmic look to them, which are the more normal electrical activity of the brain. This is actually one particular type of seizure occurring in a child who has RCDP, where you get this brief burst of high amplitude epileptiform activity, and then this attenuation with sort of semi-rhythmic looking activity that actually may not look all that bad. When you look over here, it's like, okay. But in fact, this is actually the beginning of a seizure, where this sort of, you get this overall attenuation and then this sort of like lower voltage activity compared to what was the normal baseline for this child. Another example of an EEG in a child with RCDP, and this is sleep, so I don't know if you can see the difference between this one and this one, but sleep looks often very different from wakefulness. And here, in the middle of the page, we have this area of discontinuity, where the EEG suddenly goes flat for a brief period of time. And there are some better examples of that. This is another individual who's had a number of these periods of discontinuity, and when they occur more than just a couple times, I've been calling these excessive discontinuity. But we haven't seen anybody with RCDP get to the point of burst suppression, where more of the EEG is flatline than in the burst of activity. So that's actually, generally burst suppression is considered an unfavorable progression. This is a particular pattern called hypsarrhythmia. This is not a patient who has RCDP, but this is what hypsarrhythmia looks like, which in Greek means mountain rhythm, and it's associated with infantile spasms, or in the older individual we call them epileptic spasms. But this is associated with a very particular seizure syndrome that usually has particularly bad impact on day-to-day functioning. So when we see this pattern, we tend to be a little bit more concerned about the day-to-day functioning for the person, and there's certain medications that are chosen for that. So when it comes to EEG and RCDP, first of all, it stands to reason because plasmalogen is highly represented in the brain, and because RCDP often has neurologic symptoms, you would believe that you ought to be able to see something on the EEG that would be reflective of those facts. And in fact, what we've seen is exactly that case. And this was reported before this time as well, too, from the earliest days of this diagnosis, is that these individuals do have abnormal EEGs. The abnormalities on RCDP EEGs can be observed either in the presence or absence of known clinical seizures. That somebody may never have had anything that looked like a seizure, but when we do an EEG, we see a lot of abnormalities, including epileptiform abnormalities, and that's not surprising in cases of individuals who have RCDP. And then the other thing that we see in individuals with RCDP is that there's a sort of a state separation where wakefulness and sleep can look very, very different. That the EEG in wakefulness might be very continuous. It's going to have maybe some abnormality to it, or maybe not much at all. But when the individual falls asleep, a lot more abnormality comes out, and that sometimes includes these periods of excessive discontinuity, where there are these brief suppressions where the EEG almost looks like it goes flatline for a second or two. What we found in our sequential monitoring of the EEG results is, first of all, that the results tend to stratify, that they're not sort of all over the place, that people tend to have either EEGs that are substantially normal. They can still have some abnormal features, including more or less infrequent epileptiform discharges, which more or less tend to be more focal here and there, but often on both sides of the brain, or mild non-epileptiform abnormalities, usually in the form of background slowing. But nonetheless, the individuals with sort of low abnormality have substantially normal features of both wakefulness and sleep, that we see a normal gradient of frequencies from front to back. We see normal what are called sleep transients, which I didn't show you earlier, but there are normal waveforms that look a little bit sharper in sleep that are centered right along the midline, and we tend to see those in individuals who have low abnormality. Then there's individuals who have mild abnormality, moderate abnormality. And those individuals, we say, usually always have multifocal epileptiform features, and some of these also have generalized discharges that occur on both sides of the brain at the same time and are very high amplitude. Almost none of these individuals usually have recorded seizures on an EEG, even if you run it for the 4 hours that we've been doing. All of the individuals with moderate abnormality are going to have sleep abnormality, and all of them seem to have a reduction in the normally expected sleep features of the EEG, what we call the sleep transients. That seems to be pretty much a rule of people who tend to track in that tier. And then of the individuals with high abnormality, all of the individuals with high abnormality demonstrate significant epileptiform features, both multifocal and generalized. Actual captured seizure events may be not all that frequent. We've really only caught a couple of instances, well, more than a couple, but a small countable number of instances where the EEG has actually caught a seizure during the 4 hours. But that's sort of what's called sampling. It's the time sample that you're doing. But when you do see that, it sort of usually segregates along with individuals who generally have a high degree of abnormality with their background EEG. Excessive discontinuity in sleep is also a very, very common finding in these people who have a high degree of abnormality on their background EEG and who have RCDP. So not 100% of them, but I would say probably at least 3 out of 4 have this excessive sense of these breaks in the EEG when they're asleep. There's also been several instances, all in this category as well, of individuals who have a feature called a delta brush, which I didn't think to include well, actually I thought to include, but I forgot to include a slide with it. That's basically one of those slower waveforms, what I talked about, the delta band. So you go back to this previous one here. So the delta bands are if this is time, they're the broadest waveforms that you see. Those are delta. If you see those and you have a little burst of fast frequency activity overriding it, so it almost looks like one of those harnessed brushes that are rounded and that you have the bristles on it, that's called a delta brush. And we've seen that in only a couple of EEGs in people with RCDP, but usually when you see it in one EEG, then you see it sequentially through. It's hard to know what to make of that. You do see delta brushes normally in the EEGs of premature infants. So they're a normal feature up until a couple of weeks before about 40 weeks of gestation, about term. By 40 weeks, they should be very, very rare, if at all, and after that, you don't see them at all. There's only a couple of other medical conditions where sometimes delta brushes can reemerge. Sometimes some of the autoimmune inflammatory encephalopathies can have them. In this case, they're not what you would say pathognomonic, that we have noticed it, but it isn't enough to really sort of qualify as any sort of standardization measure for RCDP. Some surprises from the study we've had so far, with only a few exceptions. We really haven't seen a lot of progression in the EEGs from lower to higher degree of abnormality over the couple of years we've been doing this so far. That doesn't mean that it doesn't exist, and I know it's been reported in the literature before, but we really kind of haven't seen that very much, at least not yet. The difference between waking and sleep abnormalities remains notable, though. Far, far more abnormalities in sleep than wakefulness. This is not an entirely unknown phenomenon, so a lot of people with epilepsy may have primarily their abnormalities in sleep and not in wakefulness. There's something about the organizational state of the brain when you're asleep that favors epileptic activity and epileptiform discharges. And in fact, some people with epilepsy only have seizures when they're asleep and not at all when they're awake. So, it's a little bit of a surprise after starting gate that we saw this, just because kind of weren't knowing what to expect. But, it is sort of seemed to be a consistent finding. And then another thing is that a few people actually seem to have a modest improvement here and there in their EEG when we compare the one before the other, at least as far as what we're talking about the burden of epileptiform abnormalities, how many sort of spikes, how much spiking seems to be. But that mostly seems to be probably related to the introduction of new medications, and particularly use of like benzodiazepines like clobazam or some of the other anti-seizure medicines. It could also be sampling error. So we've had a little bit of slight improvement, but then the next time you do an EEG, it sort of more looks like the original. So some of that could be just what we call sampling error. That it just happened to be a good day when we did that one EEG, and so things looked a little bit better than on the day that the previous EEG was done. I think the next big question that most people would probably have was, does the EEG help you at all to guide the choice of anticonvulsant treatment? Well, as a general principle, the answer is, well, yes and no. There are some general guidelines that do apply. So EEGs that show predominantly or exclusively generalized epileptiform features tend to favor treatment with only a smaller range of anti-seizure medicines. Those are listed here. So valproic acid is probably like the queen of those. It's the one that's sort of most time-honored and most convincingly associated, but benzodiazepines as well, so drugs that are in the Valium class, so that's Valium, clonazepam, also Onfi, or clobazam, is actually a benzodiazepine. It's a slightly different structural formula, but also sometimes lamotrigine, and then there's a few other drugs like verapamil and felbamate, which we really haven't seen used much in this population, that also are generally used for those. It's also, when you see a lot of generalized discharges, some drugs could actually worsen primary generalized epilepsies such as carbamazepine or oxcarbazepine or phenytoin, which is the old Dilantin. We really haven't seen, at least as far as I know, based upon looking at the EEGs, I haven't seen that happen here, that even if people have a lot of generalized abnormalities and they're on oxcarbazepine, I have no evidence that that seems to have made it worse. So that paradigm doesn't seem to apply here. EEGs that show hypsarrhythmia or infantile spasms for clinical treatment usually only favor a few drugs, such as corticosteroids or vigabatrin. Those are the ones most commonly used in the United States. And EEGs that have exclusively focal epileptiform findings without the generalized, or happening at both sides at the same time, abnormalities, those are really less selective in that many, many different seizure medicines can work for that, including the ones I've listed here for the more generalized abnormalities, as well as all the other meds that are on the market. And most seizure medicines are brought to market initially for the treatment of focal epilepsies, because those are by far and away the most common epilepsies. So it often makes more sense for companies bringing a drug to market to focus on that first, and then later they worry about getting the indication for primary generalized epilepsies. So with regard to EEG and anti-seizure medicine, the goal of seizure medicine treatment is generally agreed upon to be the reduction and hopefully elimination of seizures, but without compromising quality of life. So there's a tipping point there at which, depending upon what a person's baseline functioning is, what their quality of life is, what their age is, many other factors, there's times where living and dealing with a few seizures is better than dealing with what it would take to actually make the seizure stop entirely, because the burden of medication that would be needed might completely erase any sort of identifiable quality of life that the person might have. So, we usually try to aim for that middle ground where we have the least number of seizures possible, but also without drastically altering the person's quality of life and their baseline functioning too much. Unfortunately, when it comes to EEG and anti-seizure medicines, what we call force normalizing the EEG usually doesn't even predict that an anti-seizure medicine may fully work. That you can take some medications such as valproic acid or the benzodiazepine, excellent what are called spike suppressors, and that you can make an EEG look like it's lost most of the spiking. You'd say, oh wow, that's great, that's a terrific outcome. But in fact, some of these people still have a lot of breakthrough seizure activity. It's just that sort of on a moment-to-moment basis, you've made the brain sort of arc less electrically, but still that fundamental instability remains. And then the other thing that can happen is, there's often a honeymoon effect when you start any new anti-seizure medicine, that for a while things may seem good, but then as time goes by, you sort of lose that benefit. And suddenly you have people seeming initially to respond to an anti-seizure medicine, and then you lose that response. So of the people that we've seen in the study, what anti-seizure medicines seem to have been tried in patients with Rcdp. So here I'm a little blinded, which is not a bad thing always, as to what's going on clinically. And I'll explain why I mean that's not a bad thing in a moment. But of the medications that I know people have been on based upon what is recorded for the purposes of the EEG being done at that time, the most people have tried Keppra. Or levetiracetam, I'm sorry, I meant to put levetiracetam, which is a generic name. Gabapentin or Neurontin is sort of next. If you consider all cannabidiol to be equal, both the Epidiolex, which is the FDA-approved brand-named medication that is pure cannabidiol, and the CBD oils from dispensaries, that's sort of next on the list. Then people who have been on clonazepam, oxcarbazepine, valproic acid, clobazam, and rufinamide, and trazodone. If you consider all the benzodiazepines together, that would be the clonazepam, clobazam, and trazodone. then that sort of puts this class up into, well, they're among the more commonly used as a general class, but not as individual specific drugs. I know that may be a little unclear, but some drugs you can more or less consider the category to be either effective or ineffective for an individual, and sometimes maybe one didn't work to try another, but you can more or less consider them all to be sort of like, I think the analogy would be they're bread and bread. Some are whole wheat, and some are rye, and some are pumpernickel, but they're all bread. So has any drug shown exclusivity for RCDP as far as results? Not at this time, but I've noticed that some medications really seem to have not been tried. And those include, forefront of my mind is cenobamate, which is a newer drug that just came to market over the last couple of years. It was brought to market by a company called SK, which is not SmithKline, but it's South Korean pharmaceuticals. And it's been a real game changer in adult epilepsy. It's hard to get it for kids because it's still not FDA approved for children, but we've been able to force it through in a couple of cases. Then there's fenfluramine, which is only approved right now for Lennox-Gastaut and Dravet syndromes, but with that, I think, the indication may be broadening for that, so we may be able to sort of eventually start pushing that into this population. But right now, it's generally restricted to people with a particular genetic malformation in sodium channels. Felomate is really a good drug, but it's one of the ones that people are more afraid of, because when it first came to market in the 1990s, there was a whole series of fatalities. But that had to do with the fact that it was incorrectly identified as a drug that needed no close monitoring. And in fact, there were cases of liver failure and bone marrow failure from them that resulted in fatality. Those tended to be more in adults than in children, and particularly adults who had any history of lupus or any sort of autoimmune inflammatory condition. But it is still on the market. It's and it could be a good drug. It does, unfortunately, tend to have the activating principle of making people sometimes a little irritable. So sometimes it's a problem from that point of view. But I really haven't seen that used much, but there might be some promise there. And then, trying to think outside the box, given sort of the longevity of these EEG findings, that we're not seeing these individuals change rapidly year to year, could some of these sort of longer-term treatment strategies that are not medications be applicable? The one that I'm thinking about is something called vagus nerve stimulation, or VNS, which is an implantable device that's sort of like a pacemaker for the brain. It attaches to a nerve in the neck, though, so it doesn't require direct brain surgery. You don't have to be drilling holes in skulls and stuff like that. Use just a simple soft tissue dissection to the vagus nerve in the neck on the left side, and a device very much like a pacemaker implanted under the skin. And it supplies this interference current to the brain via the vagus nerve that tends to disrupt seizure activity. So sort of another thought would be, given now what we're seeing, could VNS possibly be applicable, for, individuals who have longevity to them and for whom doing the surgery may be worthwhile if it's going to give them a better quality of life. I think these are all sort of unanswered questions right now, and I don't have those answers, but I think that that's something worth thinking about. And I think since I started late, I think that I've already probably run past over 30 minutes. So I'm going to shut up and let you ask any questions, or if the next presenter has to get on, we can get on.
Anybody have any dying ones, or can we? We're a little late.
All right, everybody stand up for a couple minutes. We're all falling asleep. Stand up.
Thank you, Dr. Belchak. This is like the 7-minute stretch on Sweet Caroline. You're using your own.
Every time I see her, I'm like, and it hurt, and she starts laughing. I'm like, I don't get it. You're gonna say, ow, it hurts about stopping. She's like, keep catching, right, girlfriend?
Thank you.
Yes, it's good to see you.
Yeah. All right, we're already late, so you can stay standing if you want, but listen and stand.
So Candace and I were going to take the lead on this presentation. I wanted to provide some updates on natural history studies and the registry for Rcdp. Initially, though, I was going to just talk through, why we need registries in natural history studies. I think this is something that we commonly see for rare conditions. So condition is rare, meaning usually only a single clinician has only seen one or two cases in their entire life. How can we get some meaningful information about a condition, what is a part of it? Really what's needed is having everyone come together so that we can really try to understand the condition. There's power in numbers. It really helps us in potentially determining what can be associated with a condition so we can better provide surveillance. What ages we may expect a feature so that we can know when to screen. And then, from the perspective of developing treatments, it can be useful to tell us if a treatment is helpful. Now, for the registry, I just have one of the publications that's come from the Rcdp registry that describe that congenital heart defects are common in Rcdp. Really, these types of registries are good for defining concrete things in a kind of narrow window in time. So for this case, having a heart issue at birth or near the time of birth, using a registry was very helpful. So doing these studies, there are different ways to go about them. I'll be talking about the retrospective registry, and Candace will about the prospective one. In a retrospective registry, we're starting, today, and then we're going back in time and trying to collect health information, and use that information to inform the progression or the natural history of a condition. In a prospective study, we're starting today, and then we're going forward and we're collecting information. This might sound like, two heads of the same coin, so what? What's the difference? The reason is there are differences, and generally when we do something retrospectively, we're prone to bias. We don't always have the same sets of information for everyone, and when we do something prospectively, we can decide on what sorts of measures or clinical parameters we want to collect over time and going into the future. Guidance from the Food and Drug Administration also values the use of natural history studies. So rare diseases, which Rcdp definitely qualifies as one. Using natural history data can be used as a potential external comparator group. So it can be something to help inform an intervention to understand if the intervention is helpful. So, the updates from the retrospective Rcdp registry, I'll mention, of course, this is something sponsored by Rcdp. It's housed in Nemours. We have 49 individuals, roughly split 50-50 between males and females. The trial is up on clinicaltrials.gov. We do get some questions and interaction through that website as well. For Rcdp types, we have the majority are Rcdp1, with 4 individuals who are Rcdp2. 22, and then some individuals who are unknown, so we don't have their RCDP type or their genetic information. From a geographic standpoint, includes individuals from 22 states and 3 non-US countries, Canada, Australia, and the UK. So information that has previously been published, this is data that, unfortunately, kind of demonstrates the risk of early mortality for people with classic RCDP, where we can see that, by early teen years, over 50% in our registry cohort have passed away. Again, that's a very kind of discrete thing and something that going back in time in a registry can really help us, we can really kind of concretely measure. Something else that we can do well and measure in a retrospective study can be growth parameters. Every time a child goes to a visit, there's always going to be a height and a weight, and when they're young, especially a head circumference as well. So, the registry data also has helped inform the growth charts that are published and known for RCDP. So currently our plan with the retrospective registry is we're kind of hiring someone into a position to go back. I think we're about a year behind in entering data, so we want to get that up to date. And it still remains open, so we're going to continue to enroll new participants and continue to collect information on everyone involved. Great, so with that I'll turn it over to Candace.
I think almost everybody knows me here. For those of you who don't, I'm Candace. So I'll do the prospective side of things. The prospective natural history study different than the retrospective in that families are coming to us and not just looking at medical records. So I'm going to go through a little bit of an overview of what that study looks like and the kind of data that we are accumulating, and then very briefly show some data just to show that there's a lot to it and a lot that we can kind of pull from these visits. So the natural history study, the prospective study, is designed to have visits every 6 months that are in person. And so we also do 2 days back to back. Cece's not happy about this information. We do 2 days back to back, filled with lots of visits, but those visits are in person at Delaware and Moores, and also include surveys that you take at that time. So surveys go out during those visits and also at 3-month intervals. The in-person evaluation includes a lot of things. It's a jam-packed visit. So the families that come to see us have updated medical histories, feeding histories, surgical histories, medication histories, but we also do vitals, physical exam, we do a lot of measurements, and then we kind of skirt you around the hospital to all of our specialists. So currently we do a 4-hour EEG that's read by Dr. Falchek. We do an EMG, which is a nerve conduction study of the lower arm. We do some pulmonary function studies, a DEXA scan to look at overall body composition, bone density, and then with Mary Bolton we do PT and then physiatry. We also have some basic lab work that we do in addition to a sample that goes to MedLife. So the surveys that we send out are, there's a variety of them, but they cover information about GI symptoms, but also some more broad feeding assessment and those general GI concerns, trying to gauge those kind of concerns for our families. There's a pain checklist, again, to evaluate pain in individuals who can't necessarily communicate that with us. The quality of life survey, which families have worked hard to create, and then the Iowa fatigue scale, which is geared towards care providers information we kind of gather for everybody every time, which gives us a lot of long-term changes that we can see, so we can paint a better picture of what does life look like and what are the concerns that our families are raising. So we currently have 24 participants enrolled. 4 have passed away, 3 have withdrawn, and 3 were lost to follow-up. But all of our families who've come to join us, we've completed 98 in-person visits, which is amazing. Yes, round of applause for everyone. So the statistics, I don't think anyone will be surprised of our demographics. Our current numbers are pretty much 50-50, 11 male, 13 female, and current age range is 18 months to 23 years. And as you would expect, just in the separation of the different types, most of our kiddos are type 1, 21 out of the 24 are type 1, and 3 are type 2. Again, not entirely surprising to our families. Over time, certainly, we've gotten better at recognizing the diagnosis. 4 of our families report a prenatal diagnosis. Doesn't mean that there weren't prenatal concerns, but a diagnosis was made prenatally in 4. And then the vast majority were diagnosed in the infantile period, so under a year old. 8 of those being newborns. Interestingly, we're not perfect at diagnosing some of our non-classic kiddos, so 3 of our kids were diagnosed after a year old, the oldest being diagnosed at 7. So part of the question that I think we can start to gather, or part of the information we can gather from a prospective study, is trying to answer the questions that we commonly hear, right? We're gathering a lot of information over a long period of time for individuals, so we can see how they change. That's different than a retrospective study where you might only get snapshots. So some of the questions we hear often from families and medical providers. The most common questions are, do plasmalogens change over time? That's a question we're trying to kind of answer. The other questions are GI stuff, so GI and feeding expectations. What are the growth parameters? Are there other parameters that we know are more consistent or that we can create growth charts for? And do we expect contractors to change over time? These are the big questions. Obviously, there's lots of other questions, but these are the ones that are kind of easier to view on a very quick and dirty screen presentation, at least. So this is anyone who has questions about any of these graphs can ask Sean. So this is a graph of plasmalogens over time, and I'm not going to go into details on any of these graphs, but the things that you can pull out are that most of our kids have a lower plasmalogen level, indicating that yes, most of them are in the classic range, and there is some variability over time. What that trend is long term or what that means clinically, I'm not sure that we know those kind of details, but we can see that it is not stone cold like flatline, right? Like these aren't the same levels at every visit. So that kind of leans towards an answer of do these change over time? Yes. What it means on the day-to-day, I don't think we know that answer. The surveys that we provide for addressing feeding tell us what you will already know, knowing everyone that you do. So one of the questions asks about how your child is fed, and you can see that a small number of our kids are fed orally with no tubes, and then the vast majority are fed completely by tube, with a couple of them in between, kind of mixing between tube and oral. Pulling just rough data without going into any significant statistics, that's Sean's deal. But I'm just going to keep bringing you into this, Sean. So what I pulled from our data is that about 80% are tube-fed in some capacity. 13% are bolus-fed between 3 and 9 feeds, and 12 have continuous feeds. But, I mean, you guys know better than anybody, like that fluctuates, those feedings fluctuate based on what a kid can tolerate that day, and their rate fluctuates. So I don't think any of these tiny details change a recommendation for an individual. It's merely like, okay, this is kind of consistent with what we're hearing from families. The part of the feeding assessment survey also asks very specific questions. So this question asks if your child gags or vomits during or just after a feed. So one of the things that we were hearing, I think historically, and kind of has become a little bit clearer over time, is GI concerns. And so part of these questions are trying to tease out some of that. So this question, you can see, is all over the board. Yes, some children rarely vomit. Some children never vomit. Some children always vomit. But it's, you know, it's not as black and white as a simple, yes, it's a vomiting question. And that's what's causing some of the issues. But on the flip side, you can see that the questionnaire that gets to the idea of GI discomfort in general shows that a lot of our kids at some point fall within the moderate to severe GI discomfort range. Now that's based on a survey, right? So obviously there's lots of data points here. This isn't one individual. Sean, if you would like to add any details, but you can definitely see that there's variability in scores.
Yeah, I think that's everybody together. Whereas on the previous slide, just each color is a single participant. So you can see, like, there's most cases, there's no change. So like, if somebody is scoring rarely, for example, they're scoring rarely every single time they do a visit. So you've got a lot of collections on some participants. So at least, you know, from what I've seen, and this is super preliminary, I mean, the work that I've done so far has really been focused on endpoints for the phase 2 that's coming up. But this year, there'll be a deeper dive into this. But you can see, like, not many people move around. I mean, it looks like there's maybe a blue cyan dot toward the end there on the right that looks like sometimes it's an always, and then it's a sometimes, and then
Sometimes a never, sometimes a rarely.
yeah, so that's kind of
sometimes
rare.
an
I mean, there is, we do see cases like that, but for the most part, like the data that I've seen, and I'm kind of blinded because I really don't know the participants as well as obviously Canada, so I can kind of look objectively at this and go, yeah, like here's a case where somebody is reporting the exact same thing every time, versus, you know, there seems to be some variability in this, and who knows, maybe it's, you know, there is some variability there with respect to vomiting or GI. But in the next slide, that's just an aggregate of everybody, it's not colored. And the idea here was like percentage-wise, like of the question that was asked, like from all the visits combined, roughly, what are we seeing in terms of, you know, GI discomfort? And I think on that question,
Self-serve ice cream, right?
yeah, like, and yeah, that's
Ice cream!
yeah.
More about that, Sean?
I have done more than a second for that one.
So I think, you know, the answer to the feeding and GI question, I think, is still to be clarified. And certainly there's not one single answer to any of these questions, but I think, you know, some of the data is supporting what we're hearing from that.
And honestly, too, like GI's been a weird one for us because if you think back to the quality of life surveys, focus groups that were done years ago for that survey, like GI was always identified as like a major point of concern. But then when we do the quality of life questions, it doesn't really come up as like the #1 concern. So like, I agree, like it seems like it's always brought up and mentioned, but then, you know, from my side looking sort of objectively, it seems like it's abnormal, but it's like the normal for you guys. Right? So like, yeah, it's a concern, and obviously feeding and things are a concern, but it's become your like normal routine. So it seems like less of a concern when you have to answer a question about it. It's kind of the way it's looking with some of these, so, yeah.
So the other question that we can use some of this data to answer, and you guys should all know these growth curves tattooed on your arm. The growth over time, right? When families are coming to join us, we take a lot of measurements, and that includes head circumference, height, weight. So we can see that, obviously this data goes beyond, because this is only up to 20 years, but we can see that the growth curves that were previously published still hold true. We're still well within those ranges that we had published in the past for classic and non-classic, all below the normal range. This is the height one. You guys were here a couple years ago. You can thank Mike for these. And then weight. So the measurements that we take that haven't been published before are also enlightening in this regard, because we take chest circumference. We also take some other measurements that I didn't pull any slides because John didn't put it together. But you can see
She's just backing up and coming over.
it's all about Sean today. So the green line being the normal curve, this is chest circumference, so you can see all of our kids are basically under the normal curve with some growth over time. But yeah, you can see some trends. And then the question of, contractures and do those change over time, I think, the stories that we hear from families and then the objective data, I think they interplay a lot. So this is a graph of range of motion. So on the bottom, you can see range of motion of each joint. The green bar being the normal range, or roughly the normal range for that joint. And you can see for most of the joints are below. So our kids have limited range of motion of the vast majority of the joints, some of them being more affected than others. This is actually knee extension, if I'm right. Yes, knee extension being at the bottom here, which is exactly what you guys know on a day-to-day basis of trying to move them around and navigate the world. And then range of motion over time. So each one of these little dots is color-coded per individual, and you can see grossly over time for an individual, there's not a dramatic change. Obviously there's some outliers there, but I think, correct, Sean, grossly over time, this is what this is showing.
Exactly, and honestly, this is really the trend with most of the natural history data, is not a lot of dramatic changes over time, other than growth and maybe like onset of seizures, which is a little bit trickier to gauge. But for the most part, I mean, you've looked at almost every endpoint now, not a huge amount of, it's a stable, non-progressive condition, which I think we all knew, but now we have the data to really back it up. So.
And I think the nice thing about long term, right, you have the stability of an individual, and you're not then comparing them to someone else's baseline.
Well, and this is, yeah, exactly. And this is why the natural history study is so critical, honestly, because this is acting, and McKean touched on it a little bit, but this is acting as the non-control, like placebo-like group for the trial. So there isn't going to be a placebo group. It's this data will be compared to what happens on treatment. Okay, so that's why having all these visits, and especially baseline, where those range of motion graphs that Candace was showing, if you look at those by individual, the other one, yeah. So like each bar is everybody in the study. Just the dark line in the middle is like almost the middle of the mean, and then there's a distribution there. But if you look at one person, they're pretty stable over time. Like, range of motion doesn't really change much for one participant, for one child, but can be dramatically different for the next participant. So whoever's at the top with their 140 degrees is probably close in that range for all their visits. So this is a statistical challenge when it comes to therapeutic improvement, because these are large ranges. So to move the middle line in blue up or down by a certain percent and have it be significant with treatment is tricky. But if you compare it to your baseline, right, if June improves, or subject whoever improves 20% compared to themselves, that's a much more sensitive indicator. That's why the natural history baseline visits, and the more of them you have, the more power there is in the study once you get treatment. So participants with 10 visits, that's an incredible data set to say, okay, this is how you've looked for the last 6 years, and now on treatment, if something changes, you have much more confidence in that change than you do if it's like a single baseline and then something changes. Well, did it really change or did it not change? Is it just a fluke event? So we keep reiterating the importance of natural history, and that's really why, because the more visits you have, the more power you have in a therapeutic study. So yeah, I've been really impressed. Hopefully this year we get a publication or two out of this data. It's kind of the next thing that we'll be focusing on as MedLife, in addition to the trial. But it's a very powerful data set. And kudos to the team at Beamers has done an excellent job at doing the visits and keeping everybody on track and collecting all the data. Tara and I go on audit every 6 months or so, and honestly, there's little minor things here and there, but overall, it's been really a well-run study. So.
I got 10 minutes.
Yeah,
You
and
guys
that
are-
leads
we're so
us,
warm
that
up.
leads us to
Nobody
Tara.
has clinic visits after this. We can't. You have.
Well, let's get you up here then, Tara.
Well, it's just all stuff that's still coming, so. Twice.
There. That's all you, Tara.
Okay.
We're still trying to keep this on time. It hasn't gone good.
I just have a question. You mentioned pulmonary function tests. What are those findings?
Interesting. So phase angle, rich data, routine contribution. The question there being, what's the real problem? Is it like is it a bone issue? This isn't going to be the case. I think it's more like an innervation, diaphragmatic issue. Because phase angle, but RCC isn't. So when you look at labor reading index, very nicely correlated with phase angle, which is shift. It's real, but ribcage contribution looks fine. So.
So it is an innervation problem. Okay.
Except the nerve conduction tests are no different. So we don't
Yeah, so
know.
ribcage actually is normal.
Oh, wait, I'll try and catch us up on time. I also have no voice, not something communicable, I promise. Just a chronic issue we're dealing with here. So I will do my best. If it goes to crap, Sean can come up and give this in a speed. Almost all of you know us. We're MedLife Discoveries. We're from Saskatoon, Saskatchewan, Canada. We got small. There's only 4 of us. Half of us are here today. If you have traveled at all in the natural history study, you've almost certainly talked to Kaylee at some point. She was also here a couple of years ago. And then we have Vinod, who you probably won't directly talk to, but he makes sure our drug is made up to all specs and reads more paperwork than you ever want to do in your whole entire life. While there's only 4 of us, we have lots of consultants. So what we don't know how to do, we go find somebody that knows how to do it, which is why we have this beautiful team from Nemours here to help us too. And MedLife's entire goal right now is to try and bring a plasmalogen precursor through an FDA approval. That's our only, it's FDA or bust for us. Sean mentioned really quickly, but we do have some new families here, so I'm going to really quickly explain what our drug is. So the drug we're working on right now is called PPI 1011. It has the ether bond that Sean spent a whole bunch of time talking to you about on the SN1. It's got DHA, which you've heard of, and then we have lipoic acid on the SN3. This makes it a not natural product in any way. You won't find this in nature. But what it does let us do is build it in a lab at a higher scale, and it's stable longer and actually makes it like a drug as opposed to natural supplements, which tend to be very, very low concentration or have issues with, purity or stability or whatever. So it was designed to act as a bypass to all those Rcdp enzymes. So here was kind of Sean's figure from before, where we have a whole bunch of things that are messed up in the way to get to a vinyl ether plasmalogen. 1011 comes downstream of all of those. So there was a question before of like, does it matter if it's R1 or if it's PEC7 or what it is? 1011 was designed to make it not matter. It comes in, halfway through the assembly line, past the parts of the machine that are broken, and your body should be able to convert that into a plasmalogen just like all of you are doing right now. We just skipped a few steps. So to give you an update on what we did this year, it was a really busy year. So I'm going to start with, we finalized the Rcdp Voice of the Patient report. So if you were here last year, you know what a massive undertaking that patient-focused drug development was. It was so great, and I'll talk a little bit more about what we found from that. But finalized, that report was big. We finally published the Rhizo Quality of Life, which is also another big thing this year. We published the phase 1, and I'm going to go in and talk about each of these things in detail. But just to give you an overview, we designed and started a 9-month safety study with 1011 in primates. We have made kilograms and kilograms and kilograms of drug and shipped it around the world. And this is what kilograms and kilograms and kilograms of drug looks like. It's an entire pallet. It was 300 and something kilograms once it's packaged and put in bottles and shipped. And then we did, and somebody who helped us, we did a pilot on a blood collection device because everybody last year said central phlebotomy was their least favorite part of our trial design at the time, and so we went away and tried to fix that since last year. Oh yeah, we submitted an IND. Sean stole the thunder earlier, but this is what we've been trying to do for years, and it was submitted only weeks ago. So that's great. And if you are new here and you don't know what an IND is an investigational new drug application. Before you can give a drug to a US person, you need the FDA's approval. They have to review it and say yes. And so that's what we finally did. It's in to the FDA.
So that's an experimental evaluation.
Before you can do a trial,
yes.
Right? This doesn't sell a drug. An IND is investigating a new drug to see if it works. So what goes into an IND turns out way more than we even thought. So you have to discuss the disease and why you think that the drug should work. So this was a really big part of our IND and a really big part of what we use the voice of the patient for. Because kind of like Mahim and some of them have said, some things are out there in the literature about what's Rcdp and some things are not. So I can't just throw a whole bunch of references up like if I was doing Alzheimer's or Parkinson's and just assume the FDA knew what the disease was. They've never heard of Rcdp, they don't know what it is, and they don't know why we are proposing this drug might work. So that took a whole bunch of time. Then you have to tell them how you're making the drug, how you're formulating the drug, how you're going to give the drug. You need a ton of animal safety studies and in vitro safety studies. In our case, we have a phase 1. So typically an IND would be a first-in-human situation, first time any human had gotten it. But we did a phase 1 in Canada, so this is not the first one, and I'll go over those results briefly as well. We did include some information from the natural history study together with the voice of the patient to support those endpoints. And then what is our phase 2 going to look like? What's the trial that we're asking their approval for? In the end, it worked out to 375 separate PDF files. It was tens of thousands of pages, I kid you not. It was an absolute massive undertaking that we maybe didn't realize as much as it was, but that's where it is. So it's been submitted. Now what, right? That's all anybody cares about. So, yeah, you don't just submit it and then walk away. Now the FDA does their job, right? So the FDA reviewers will now consider the risk-benefit ratio. Does it make sense to run the trial? Is it safe? And does it potentially benefit the Rcdp population, right? Is it worth the risk? Because every drug comes with a risk to do the trial. That's their job. And there's reviewers from all over. There's reviewers that look at the rationale and the scientists and the scientific sense, and the medical reviewers that look at it and say, does this pass a sniff test of it's worth evaluating in people? There's people that look just at how the drug was manufactured. Did they dot every I and cross every T and follow the rules and use what's called good manufacturing practices, GMP? Did they do everything as they're supposed to so that what's in the bottle is what they say is in the bottle? That's a big deal. Do they have the available safety data? Can you support using animal data, and in our case, a phase 1 human study, the support of how you want to use the compound in the study, right? Do you have enough data to give them the warm fuzzies that this is probably going to go the right way on that? And then, is the phase 2 design, the trial that we've proposed, is it reasonable, right? And reasonable means, one, that the patients are reasonably likely to be safe, but will it generate good enough data that we can make decisions about whether the drug works or not, right? Just getting it into kids is only one part. Like Sean said, if we didn't have the natural history study, we could put it in the kids, but we would have no idea if it changed or not, because we wouldn't know what to expect. So that's what the reviewers are going to sit down, and they kind of like chop up our huge package into packages, and everybody reviews their specialties, and then they come back and they say yay or nay on the risk benefit. Oops. So at the end of all of that, they can ask questions at any time they want. They could email us today, they haven't, but they could, and ask us just to clarify things, right? What do you mean by this, or what do you mean by this, or can you provide the paperwork to support this, or something. But at the end of their review, they can either do two things. They can say, yes, go ahead, do the trial, yay. Or they can put us on what's called clinical hold. So I'm going to go through what both of those options kind of mean, but those are the two options at the end of this that we end up with. We either go ahead, or we get put on clinical hold. We'll start with clinical hold, because that's the one that would slow things down. So the agency can put a study on clinical hold for really whatever reason they want. But typically, it's that they want to see additional safety data, or they want to understand the safety data. They don't get it, how we put it in there, and they want to ask more questions or see more data. They want to see changes to the protocol. So maybe they're going to say, and I'll show you our protocol, but maybe they'll say, I don't think 12 months is long enough. I don't think you're going to get the scientific data you need. Or I think you should be doing more assessments more frequently. Or I think you need more patients or less patients, right? Like they could ask for any change to make sure that they're comfortable that at the end of the day, the trial will give them data they can use to make a decision on whether the drug is approvable, right? And then goes out to people not in the clinical trial. So that's the different clinical endpoints. They could say, we want you to measure something else. This can be a problem in rare diseases because they have endpoints that they're comfortable with, and those endpoints are very rarely relevant in rare diseases, right? So a big one is in spinal muscular atrophy. They got stuck on something called the 6-minute walk test forever, which was how far you can walk in 6 minutes. This was a stupid test for people with SMA because a lot of them couldn't walk anywhere in 6 minutes. So walking further was not relevant to the disease. So we have to make them understand why we picked the endpoints that we picked. They could want different inclusion-exclusion criteria. They could want us to include more people, or they could say, we don't think it's safe for this specific subpopulation, so we'd like you to start with this population. Maybe they want us to start with older Rcdp kids. Maybe they, like we talked earlier, think the most benefit comes from the younger ones, so they want, that's a discussion we could have with them. Or they could have concerns about our manufacturing. We don't have concerns about our manufacturing, but I'll be honest, this is often a sticking point with the FDA, and unlike the other things, we don't have to submit as many reports from that, so they may just want to review that in more detail, or understand the steps, or where we bought the DHA from, or how we confirmed the DHA was what we said. So, clinical hold does not mean you can never do the trial. Clinical hold means they don't yet have the information to make them comfortable. So it's the start of a conversation where you just go back and forth until you can convince the agency that it's the right decision. The trouble with the clinical hold is I can give you absolutely no idea how long that conversation takes because the ball's kind of out of our court right now. We've put together absolutely everything we can to them that we believe is the best package. But what they ask for and how long they take to get back to us is a little bit out of our hands. So I can't tell you how long a clinical hold is going to take. I can tell you that because we've never put this program in front of the agency before, right? We did our phase 1 in Canada. It's not completely shocking if we get some from a clinical hold, because again, the agency's never heard of Rcdp. So there could be some education that needs to happen there for us to like really convince them that the risk benefit's the right way. We're hoping not, but if for some reason that's the news that comes out at some point, it's not an unforeseen consequence. It's just a conversation where we have to give more data back and forth and figure out a way to move forward. So that's possible. The other possibility is they say, hey, yes, you guys have done a good job, you can go ahead with the trial. Just to make sure everybody understands, if we get approval tomorrow, the trial does not start the next day. There are a lot of things you still need to do once the FDA says yes. And one of those is we need to get ethics approval, right? Every time you guys come here to the natural history study, you sign the ethical informed consent form, right? So we need to get ethical approval from the study, from the Nemours IRB. That can sometimes take time for them to review and do. We don't know what that's going to be. We're hopeful because it's largely a continuation that at least they've seen a lot of these assessments in our CDP patients before, and maybe we're okay. Again, Nemours will be the only site, so they're the only IRB we need to get it through at this point. We also technically don't yet have a contract with Nemours to run the study. We have these lovely people agreeing to do it, but we need contracts for the clinical hospital and all the companies and the shipping company that will ship you the drug, and all those contracts, we've started it, but until the agency says check mark on the protocol, nobody wants to finalize anything because assessments could change, timelines could change. We have to develop a database, which means each and every single little data point that we get, right? Your growth in centimeters has to go somewhere. It has to go into an online database that's tracked to a number that you guys have been given so that we can then do the analysis. So all that has to be finalized first. We have to work with these people have been doing these assessments for a very, very long time, but unlike the natural history study where maybe sometimes we can do an assessment and sometimes we can't, and maybe we started out doing it this way, but now we like doing the physical therapy part this way, all of that has to be like locked down, standardized in order for the data to be good enough for them to accept. So there is some finalization on exactly how we're going to do every one of the assessments. We have to train all the study staff. The Nemours team is largely trained, but there will be home nurses doing some of the safety assessments, which I'll talk about in a minute, so they all have to get trained. We have to get all the supplies. We have to get the drug to you and to Nemours and figure out how all that's going to work. And then obviously we have to make schedules for whoever wants to come and travel, and all of that takes time, right? So let's talk a little bit about what the trial that we have proposed is. Now I say proposed because again, until the FDA gives us a check mark, any of these things could change if it's what they think is best. But what we have put into our IND is that we're going to go with 15 to 20 patients with confirmed Rcdp. So that's what we need. And because we've had 24 patients through the natural history study, we think it's reasonably acceptable that we could do this. This is huge for a rare disease like Rcdp. So Rhizo Kids gave us numbers that they know of 37 living patients with Rcdp right now, and we're proposing to the FDA to go to them with half of that. That's more than most rare disease drugs would go to for a clinical trial. So we're very hopeful they don't say more patients because there just aren't. It's not possible. The study right now is 12 months on drug, and there's the possibility of an extension. Lots of rare disease trials have extensions to just prove enduring benefit, or what if it takes longer than 12 months to see a robust change. That's what we would do. The next one has kind of a timeline, but there's both in-clinic assessments and then there's home nursing assessments that are just for safety. As far as once the protocol is set in stone, eligibility decisions, scheduling, that all moves over to Nemours, not BedLife, right? Once we've got the protocol and we set it in stone, it kind of becomes what it is, and it moves over there. So I don't have a start date. I know that's everybody's question. I don't know when it is. We are taking one giant leap forward, and now it's just a matter of trying to get there as quickly as we can. So it cuts off a little bit, but this is what the study will basically look like. It's not a whole lot different than you've seen in the past. So your longest visit will be your baseline visit. So when you come to Nemours for the very, very first time, you're going to do an entire set of baseline assessments, which is like a very mildly shrunk down natural history study visit. So we've taken out DEXAs, we've taken out nerve conduction. I think that's it. Most of the other assessments are exactly what you guys have done in the natural history study. So you will come, and we've shrunk the EEG from 4 hours to 2 hours. So that's going to take a couple of days. And then just so that we can all be nice and comfortable and safe, the first 3 days that your child is on the drug, as Sean mentioned, there's no placebo, so everybody that comes is getting drug. And it went great in the phase 1, but to make sure the first 3 days of doses, your child will get the dose in the hospital and you'll stay there for 2 hours under observation. You're not admitted for 3 days, or at least that's not what we proposed, but somebody's just going to watch and make sure that everything goes well. We don't anticipate anything, but that's safer for everybody. Then you will go home, and we will make sure the drug gets to you. And then you will have a home nurse come in about every 3 weeks for that first chunk. And they are going to ask questions, they're going to make sure you've got no issues, they're going to ask questions about AEs and if any drugs have changed. And then the big thing is they're going to do a blood draw with the device that we piloted. So I'll talk a little bit more about that later, but if there's no safety concerns, we do not anticipate central phlebotomy being part of these visits. Obviously, if a safety concern comes up, phlebotomy is always on the table, but everybody would agree if there's a concern, it's worth the poke, right? So then at 12 weeks, you're going to come back and you're going to go through all the assessments that you did before. This time, you do not need to stay for any doses, right? So you'll be there 1 to 2 days. We'll do the set of assessments again. Then you're going to go home again. And at this point, a nurse is going to come every 4 weeks to your house. Just make sure everything's going well, do those same safety assessments, ask the same questions. You will have a phone number at any time in here if you think that there's an adverse event or something you want to talk about. You don't have to wait till the 4 weeks, right? Somebody's always available. You'll come back at essentially 6 months, but working out to week 28. You will do a third in-clinic visit, again 1 to 2 days. You will go back home. And then, because by this point, if everything's looking really good, we have less safety concerns, we're proposing those home nursing visits to now just be every 2 months. Because, the whole 6 months is a long time to not see anybody, but the longer everybody's on the drug, the less kind of concern there is for an acute safety concern that you guys wouldn't see. And then the final visit right now is planned for 52 weeks. So you will come back for one last assessment. And we will see what happened. Obviously, everybody's 52 weeks won't be at the same time. So the trial will either extend, or if you are on the trial, you will continue to have, it's been proposed that you will continue to have access to the drug until such time as either it's FDA approved, or the decision is made that it either wasn't safe or wasn't effective, in which case there's no reason to be on it anymore either way. But whether there's trial obligations to come back for more assessments or just safety obligations post the 52 weeks, we don't know yet. So these are pretty much the same assessments. You've got some caregiver reported like surveys, you've got meds, you've got physical exams, vital signs, EEGs, blood draws, and physiatry, PT, and pulmonary function. So all the things that you guys have already been doing. Nothing different there. Just like I said, all patients will be dosed at the start. So dosing will be once a day by either oral or feeding tube, whatever works for that patient. The bottles are 60 ml glass bottles, and I have some here to talk to whoever wants to talk to me about how this is going to work. The proposing starting dose is 50 milligrams per kilogram. Just remember that when we go to the phase 1. Because that'll link over to the results from the phase 1, with a hope that we can escalate if it's safe in all the patients to 75 milligrams per kilogram. So you'll be dosing your child based on volume, which will be told to you by the pharmacy. Days 1 to 3, you're going to be in clinic and somebody's going to watch you before you go home for at least 2 hours. And then after that, the first vial that you take home, you'll take with you, just to ensure that during travel you have enough, and then everything will be shipped to your house after that. And as I said, study nurses specific to this study will be trained. It will almost certainly be the same one, maybe two nurses that will be hired for your region for this study alone. So you will be seeing the same person as much as we possibly can. So you're not just having a random stranger come in your house every 3 weeks. So what they'll do is a review of your meds and adverse events, symptom-directed physical, so if you tell them anything's off, they can do that. Vital signs, and then the safety blood draw with the tap device, which I'll show you in a minute. So that's the end of the phase 2 design. Do we have questions about the phase 2 in particular? You can ask after, but I'm going to jump to the other things we've done this year, and then you can come back if you want. So we did initiate a 9-month primate study. We are very hopeful that the FDA does not want to see this prior to starting the trial, because it's not done yet. But we do think that, and what we've been told by all of our consultants, is if the phase 2 is successful and we go to get the drug approved to put on the market, they're going to want to see a second species of safety. We've done 6 months in rats, but we have not done a long-term primate study. Primates are hard to come by, and they're expensive, and they take a lot of drug, and so it has been put off. But we have started that study. Sean and I were actually in China earlier this year. That's where the study is going, because the best research monkeys exist in China. So they're getting the animal, or they're getting the drug just like you, once a day by gavage, orally, and safety is really the only outcome in that. 1011 manufacturing, I mean, this is an area I don't know a lot about. I know we made a big 10-kilogram batch, which largely went to the primates. We're almost at a 15-kilogram batch. This is what the vials look like. So they're 60 mils. They're very similar to the Epidiolex bottles. If you've ever gotten the Epidiolex bottles, they'll come with this syringe that has the stopper in it that goes in for a slip tip. We know many of the families are no longer slip tip, they're ENFit. So in my purse is some ENFit adapters that if anybody has time to come talk to me either later today or tomorrow, I want to make sure that they'll work for you so that we have all the supplies in place before we start the trial, because it sucks if we get yes on the trial and then nobody can give the drug. We anticipate for most of the patients, a bottle is about a month, but it'll be based on weight. So for like Jade and Jordan, it would be more, right? Because they would weigh more than for men. It's just the way it'll go. We got our phase 1 paper published in a peer-reviewed journal, which is great, and I think really helped our IND, because it's not just us saying it was good. It's gone through the full peer review process. There was some questions when I put out to say, like, what do people want to hear about this year? One of the big things that they wanted to hear about was the phase 1. So we did talk a bit about it last year, but now we've been unblinded. So there was 2 parts to the phase 1. There was a part where everybody got a single dose. One time, and then we stared at you for 4 or 5 days and just made sure nothing bad happened. So in the single ascending dose, patients went from 10 milligrams, a different group in each of these, but some patients got 10, some got 25, 50, 75, 100 milligrams per kilogram in the adults. So there was a specific question about if we noticed one gender had a better response or more safety concerns. There was no gender-based differences in our study. But again, healthy adults. Primary side effect was mild gastrointestinal. We're talking nausea, inappetence, but nothing that was considered more than mild and nothing that required treatment. So self-reported. Now this is what happens with the drug. So the gray line here is the people that were given placebo. So you can see after a single dose, over the days, nothing happens if you got a placebo, right? That's exactly what you would expect. Then it goes up 10, 25, 50, 75, 100. So we see a nice clear peak. It peaks about 48 hours after we give the drug, and there's a dose dependence. So the more drug we gave, the higher the plasmalogen level. So this is plasmalogen in the serum. So these patients converted 1011, it finished that little pathway out. And this isn't measuring 1011, it's measuring the end vinyl ether plasmalogen. But a single dose is only so good. That's not going to help any of the kids, right? We don't one time give your kids good plasmalogens.
And that data blew our minds.
This was like we told the
never
FDA that
expected-
everybody would look like the gray line.
Like in an animal, that does not happen.
Yeah.
You can give a single dose and see almost nothing. You need to accumulate over time. So humans are a different ballgame than any animal. We've studied like multiple different species now. This blew our minds that with a single dose, we could get like a perfect dose-dependent augmentation like that. Anyways,
No,
like
it's not wrong.
we're
It's
like,
root fault
is this for real? I mean, we're completely blinded to the whole
'Cause-
study. We don't like the whole study was done at a third-party
everybody was
site.
blinded. Yeah.
So yeah, it's, we were shocked.
And I mean, again, these are healthy people, right? They don't have deficient plasmalogen levels, so we went above normal levels and really didn't see any safety concerns. But the SAD is exciting, but the MAD's really exciting. So the MAD is where we gave them an oral dose every day for 14 days, same person. And that entire time, they stayed in a facility. That's what you do at phase 1. Can't stress enough that in true phase 1, you watch them all the time, make sure that the safety is there, you're continuously monitoring safety in these people. You don't just say, well, they came back 2 weeks later and said everything was fine. Like the number of blood tests and ECGs and urine tests and whatever these people had over the span of those 14 days is absolute craziness. That's why it took us so long. And the actual report for this is 10,000 pages long. So they either got 75 or 100. So the 75 is the red, the 100 is the purple. We didn't see a huge lot of difference between 75 milligrams per kilogram and 100 milligrams per kilogram. Levels go up and up and up and up, and then they kind of plateau, which is exactly what you want. You don't want levels, like Nancy said, to go up to this huge value that is way more than the human body wants. The human body seems to have a way, which this we do see in animals, of taking in the ether and then eventually saying, I've got enough, and treating it like food and pooping it out. The levels don't go up. Like it would have actually been bad for us to see it continue to go for the rest of time. Also, we saw no notable difference in safety between the 75 and the 100. So if you remember back to the phase 2, we're going to start at 50 milligrams per kilogram because we don't know what's going to happen to the kids, and we're going to max at 75. Because in our opinion, there wasn't, over the span of a year, there's really no benefit in going to 100 milligrams per kilogram. It means more volume, which means more oil, which could potentially mean more GI side effects. I will say in the MAD, which was 14 days, mild GI side effects were again the most commonly reported side effect. Almost about half of people had some level of GI side effect. It did not get worse over the 14 days, so like one person had it on day 7, but then not again, and another person had it on day 5, but then not again. And they were pretty much equal between the 10-11 group and the placebo group. So it's giving people a bunch of oil. These were actually 25 mil, like the big 25 mil syringes of oil every day was what these people took with a fatty breakfast. So you get McDonald's, pretty much, and then a big oral syringe of this, and then they sit there and stare at you for hours. And so even with all of that, we got mild GI being the biggest thing. There were some blood levels that changed, which we believe were also kind of GI related. Again, mild, did not require intervention, but that is why safety blood draws are part of the test, is just to make sure that we don't miss anything in your kids. So overall, a way bigger study. Like if Sean and I were gambling, like as we're staying at the casino, we would not have bet on this study going this way. We would have lost money. It went better than even we dreamed it would go. The side effects were pretty much exactly what we thought. We thought people might not like taking a whole bunch of oil, and that's what we got. But it didn't get worse over time in the MAD, which was our concern, right? Like if you take it every single day, is it going to be worse? We saw absolutely none of that in the MAD. Better uptake than we expected, and strong support for 1011's ability to increase plasmalogen levels, right? We actually don't see it, and put this in here. 1011 itself, we do not see in the bloodstream. We measured it in every single one of these patients multiple times throughout the study. The 1011 drug with the lipoic acid, that's the unnatural part, we don't see. So that part comes apart into two naturally occurring things, and that's what your gut takes up. So, I mean, theoretically, it's kind of like taking two fancy supplements, but your body processes it slightly different. But we didn't see any 10-11, and we used all of these results to decide on the phase 2 dosing, which is the starting at 50 milligrams per kilogram. At least the first 3 patients will have to do that for 28 days before we make any decisions about if we're increasing or not, but it may take longer than that to decide. So when I came last year, I thought I had a really, really great study. Like, I was ready with the phase 2, and then pretty much you all told me, I don't want to do the study, or I would be reluctant to do the study if there were as many central phlebotomy pokes as you have told us there's going to be. We don't want to do that. And so I said, okay, let me see what I can do. So we went away, and we found this TAP microselect device. So you see this little white thing on the side here? Some of you families helped, right, with this? But essentially, it goes on your arm or leg or whatever flat surface you can get, plunges down, and it looks kind of like those blood sugar monitoring things that do the like ring of needles. Anyways, and pulls capillary blood, very small amounts of blood, into the tube that's hanging down off of the side. So I tested it, no real pain. Candace ripped it off my arm, and I had a bruise. Candace, I hate to tell you this, but these families all did it, and not one of these kids bruised. So we did it real wrong. So I had the worst experience.
This is how Candace read the instruction. We don't need these.
So thank you to the families who read the instructions better, because y'all did better than we did. So we went out, got ethical approval to test this on 5 families, 3 blood draws per kid. I'll be honest, getting a sufficient volume, if you were one of the families that helped us, was a problem. You will know, no offense, but the parents will no longer be doing this blood draw. That was actually never the intention. The nurses will be trained to do that, and I think that with the nurses' help, we will be okay. We've also written it in the protocol that if need be for that safety study, a second TAP microselect device can be used at the same time. Like, if they can't get enough right away, they'll pick a different spot and try again. We're trying to eliminate central phlebotomy. I will say that the results were, well, blood volumes were a challenge. Most families had really no problems with pain, discomfort, keeping the device in place. And across the board, we sent out a survey with it. It far outranked central phlebotomy. All families said they would prefer to do this than central phlebotomy. So, yeah.
Were the plasmalogen values similar? So is this capillary versus serum?
So this is not for plasmalogen analysis. This is for safety for liver function testing. So when you go to Nemours, you will still get a central, like an actual blood draw at the Nemours facility those 4 times. That will be used for PK. There was not sufficient volume to do all of the safety, although your ethics form will say if there is sufficient volume, we're going to throw it in the freezer and as an exploratory endpoint, try and get plasmalogen levels out of it. But I think the TAP microselect was a big benefit to the trial, and I thank you all for last year telling me that this is the crappy part of your trial. So if you've heard anything in our trials that you think is a challenge, please come tell me, because we can try and find ways to get around it. Another big thing, and it took far too long, but it is what it is the RCDP quality of life was published in a peer-reviewed journal with Motiony. This is great. If you were here in 2018, you almost certainly participated in our focus groups at that time, and we have been working since then to turn this into a survey. You've taken it in the natural history study, but now it's a published survey that has a little bit more data behind the reliability of it as a useful endpoint. It will be an exploratory endpoint only in the trial, which means if we see a difference in something like range of motion, we will use this to support that's helpful in the patient's life. And then the patient-focused drug development report. You guys, this was amazing. It was formally released earlier this year. I truly believe, much like the books you guys got today, this is an enduring resource. You can use it with your doctors, you can use it with other families, new families. It tells the story of RCDP from RCDP. And so it was a pleasure to put together and help you guys with, and I think it will long live. It formally captures the realities of what Rcdp is and what you guys want to see improvements in. It did change what we submitted to the IND. So like we used direct quotes from the report in our IND submission to support, one, what Rcdp was like and the severity of Rcdp, and two, the importance of endpoints, particularly the physiatry PT ones. They were not high on the radar before the PFDD, and now they're one of our highest ranked endpoints. So you guys really, your opinions last year did change the course of what happens, and it will either work or it won't. So we want to thank you. Thank you for coming to the natural history study. Thank you for helping us design our phase 2. At this point, we sit and wait, and we figure out what the FDA is going to say, and we do our absolute best. I think what we can kind of confidently say is we think it's probably pretty safe, right? We've got the phase 1. We think we've got a good chance of raising plasmalogen levels. We've been honest from the start what that means in your kids and how that changes from one kid to the next is kind of where we don't know now. We're getting into uncharted land. Mice don't look like people. Primates don't look like people. Nobody acts like people. So we've just got to now hopefully put it in the kids and wait and see. And hopefully in 2 years we're back here with great success, but I just don't know. But I feel like we put all the pieces in to figure out, to at least try it. And that's what we've all always wanted. So, is there questions? Yes?
I have 2 questions. One is that if you have the human safety data, why you guys need to do the primate if it's just an LT primate?
There's these things called FDA guidances, and they just make you do it. There's check boxes. The general requirement is 28 days in a rodent, non-rodent, at 6 months in a rodent, and 9 months in a non-rodent. So it can be primate, dog, mini pig. Dogs are really bad species for lipids because their stomachs don't work well with oils. Mini pigs are huge. I don't know what you guys thought of mini pig ones. They're like, the amount of drug that we calculated to do in mini pigs would be 10 times the amount we ever expect to give to our CDP kids. So mini pigs wasn't an option. So we went with primates.
And my follow-up is, did you have a guys in your study before you went at that level, any humanized mouse rodent that you could try and see how this...
Well, so there's a number of RCDP mouse models, right? And so RCDP mouse models have been good at proving that we could raise plasmalogen levels. We knew we could do that. Clinical assessments in the mice are challenging. Like, we'll just be honest, they don't look exactly like an RCDP. We tried working with Johannes on a lot of his animal models. Behavioral can be challenging. All of a sudden you think it's good, and then the animals just decide they don't want to find the marbles anymore. And when you do, in all the groups, they just don't bury marbles anymore. I don't know how rodents' minds work. But yes, I mean, I have been working on this since 2009. So this is not like we just got here. Like, this is a long process, and we have a lot of studies on it. But we're now like where we tried to be in 2010.
Good job.
We did some.
Okay, if there's no other questions, please come find me either tomorrow or later today or tomorrow if you have a minute, so I can talk about like how we actually have. I brought the syringes and some of the other stuff, and I want to just make sure it works for most of the families, so that if we have to find different adapters, we can do that now. Thanks, guys. And I did it. My voice stood over.